have with us this evening Dr. David Dargis, who is a board-certified general surgeon at Spectrum Health Pennock Hospital in Hastings, Michigan. Dr. Dargis earned his medical degree from Philadelphia College of Osteopathic Medicine in Pennsylvania and completed his general surgery residency at Botsford General Hospital in Farmington Hills, Michigan. Dr. Dargis is a fellow of the American College of Osteopathic Surgeons, and his clinical interests include minimally invasive surgery, endoscopy, gastrointestinal, foregut, and anti-reflux surgery. Welcome, Dr. Dargis. Absolutely. We also have the pleasure of a patient joining us this evening. Amy Glasgow had her TIF procedure performed by Dr. Dargis in November 2022. Thanks for joining us, Amy.
Thank you.
Well, I want to remind everybody that this is a live webcast. We are happy to have you with us. Please go ahead, put in any questions that you have for Dr. Dargis or Amy in the comments section. We'll get to those throughout the broadcast as we're able. So Dr. Dargis, let's go ahead, kick things right off and talk a little bit about GERD. Can you tell us what it is?
Sure. GERD stands for gastroesophageal reflux disease, which is a loosening of the valve between the esophagus and the stomach. There's a valve, we refer to it as the LES or the Z line or the gastroesophageal reflux valve. And when that valve loosens or gets compromised, you can have acid in the stomach, and the stomach is well designed to handle acid, reflux up into the esophagus, which isn't so well designed to handle acid, and that can cause symptoms. The typical symptoms that we talk through are heartburn and regurgitation, abdominal bloat, nausea, but we also need to think about some of those atypical symptoms, some of those symptoms that people don't always realize are secondary to reflux, such as chronic asthma, community-acquired pneumonia, difficulty swallowing, frequent swallowing, hoarseness, poor dentition in the back of one's mouth. Those are all things. Bad breath, discomfort in the ear and nose. Those are all things that we need to think through as well.
Thank you for that. So, Amy, can you tell us a little bit about when you first noticed your symptoms and what you started to experience?
I think I started when I was probably in my early 20s, but didn't really realize it was just, oh, I'll take some Tums, it's fine. But as I got in my 30s, I started taking Nexium, and then I realized I've been on this for a long time. It's not really working anymore. And I talked to my primary care, and I started taking omeprazole, and it worked for a little while. And then I had an incident where I had the chest pain and all that fun stuff. And I was like, well, this isn't fun. So I went to the ER and got that worked out. Wasn't a heart attack. Started taking more omeprazole, and then I tried Protonix. That didn't really do much, and I just decided I didn't want to take medicine anymore or wonder if I was having a heart attack.
Very good. Yeah, I often hear of that sensation, especially from women who feel that they have that insane pressure and the left arm thing. So that's amazing to me. Okay, so Dr. Dargis, so how do you, when you're talking to your patients, how do they tell you that they've attempted to manage their GERD, and what are your recommendations for it?
Typically, they are coming from a family practice setting, and they have worked through the eliminating some of the foods that trigger the symptoms, timing of meals, typically 2 hours before they go to bed, try to eliminate smoking, sleeping upright in a chair, 2 pillows, propping their pillows, and eliminating weight. Getting back to ideal body weight oftentimes will help placate those symptoms. Usually they've worked through that. And then they have migrated into the Tums, Rolaids, and the used to be the H2 blockers, Zantac, more currently Pepcid. And then they migrate into the PPIs, Nexium, Protonix, Omeprazole, Prilosec are the real common ones. Uh, and then they migrate into double or triple what the FDA recommends. They're not taking one pill, they're taking two or sometimes three or four. And 90% of the patients that I see have been on a form of what we call a PPI or proton pump inhibitor for greater than 5 years. And they have breakthrough symptoms. The pills aren't working anymore. The pills are, whatever form, they're a band-aid. They're a band-aid um, to nullifying the acid, to making it non-acidic, but it really does nothing for the actual reflux of fluid coming up in beyond that juncture between the esophagus and stomach and into the esophagus and sometimes down into the lung. A common complaint amongst patients is they wake up in the middle of the night choking. So if we look at the migration of treatment, it's lifestyle modification and then medication, and typically then they'll come and see me secondary to breakthrough through symptoms.
Excellent. Thank you. Amy, was there anything specific you tried? I think you and I talked a little bit earlier about managing your symptoms. What were some of the things that you tried?
Even after twice a day of omeprazole, I'd still use Gaviscon. Just like the liquid, you could feel it coating your throat, so that was awesome. But I found myself using that more than I probably should too. I never was a big Tums popper, but yeah,
Gotcha.
those two.
Gotcha. Yeah, my husband has the Tums sitting in on the counter, so I can appreciate that. All right, Dr. Dargis. Now let's kind of dig into what unmanaged GERD can lead to. Why is this something that we want to tackle and remedy?
Well, if as the disease process migrates and pills become less effective, you can evolve esophagitis, which is inflammation of the esophagus, which can lead to ulcers and bleeding. Uh, that in certain conditions can also lead to something called Barrett's esophagitis or Barrett's esophagus, which is considered a precancerous condition. Barrett's esophagus in the general population represents about less than 1% of the general population. But in white males over the age of 40 with chronic reflux, the incidence goes from 1% to 14%. So it really increases significantly. So in that, specific to that population especially, we have to watch closely for Barrett's.
Very good, thank you. Amy, anything you want to share on the Barrett side?
I do have a close family member that does have it, so that also made me want to go see Dr. Dargis because I know it's more common in males, but still worth looking into and not having.
Yeah, absolutely. Well, and I'm
Yeah, Wendy, not to interject here, but the other condition that I've seen with chronic reflux, and we're talking about months, if not years, of this disease process, is stricture. Something we call in the medical world Shatsky's ring, where you have so much reflux coming up into the esophagus that it's like cutting your hand in the same spot over and over again. It'll heal and it'll reheal, and eventually it's going to create a significant scar, and that can happen in the esophagus as well.
wow.
Treated a little differently initially, but reflux can lead to stricture as well.
And then with a stricture, what kind of symptoms or what kind of side effects does a patient suffer from something like that?
Typically, it's difficulty swallowing or painful swallowing. The common complaint is pills getting stuck, and or going to a meal out in a restaurant and having to go to the bathroom and bring it back up. especially strided meats like chicken, pork, steak. Those are typical symptoms. And of course, in the severe circumstances, having to come to the emergency room to have a food bolus removed from that area because they just can't bring it down with fluid or swallowing.
Understand. Okay, thank you. So, can you talk a little bit with me about the tests that you order when you have somebody who is suspected of having GERD?
Yes, when you come in, the initial test is going to be an upper scope, an EGD, esophagogastroduodenoscopy. And that's where we, under light sedation, you have to be, nothing to eat or drink after midnight the night before. You come in, we give you light sedation, and pass the scope down into the stomach. And that gives us a lot of information. Tells us what is the degree of esophagitis, if you have it. What is the size or existence of the hiatal hernia? Not only can we decipher whether there's a hiatal hernia or not, but we can measure it, certain diagnostic measurements. And we can biopsy. If something looks suspicious for Barrett's, we biopsy. In that same setting, while you're under sedation, we will place what's called a pH Bravo capsule, which is a small little capsule which not only measures the amount of acid coming up, but it also we can determine how those symptoms relate to the reflux. Now, the real kicker on this, and a lot of patients have issues, is you have to be off of the PPI, off your medications for 10 days prior and 4 days after we place the capsule. Because I need to get a baseline on just how bad this reflux is. But it's a great test, and it gives us a lot of information. It gives us something called a Demeester score, and probably more detail than we want to get into right now. But suffice it to say, it not only can tell us how much reflux you have, but also if the regurgitation, the nausea, the heartburn has to do with the reflux itself. Um, so that's the second test. First test, upper scope. Second test, pH Bravo. Third test is a motility test called an endoflip. While you're under sedation, takes an additional 1 to 2 minutes. We measure the pressures in the esophagus to make sure that the food can move from the mouth down into the stomach. There's a minority of people that have something called achalasia or a dysmotility disorder, and we want to rule that subset of people out. So 3 tests, all of which are done in that same setting, uh, each of which takes an additional 3 to 5 minutes to do. It's not a very lengthy procedure. And then, so those are the 3 tests that we do in that setting. And then on an outpatient basis, we'll measure something called gastric emptying, gastric emptying study for, again, a minority of people that may have gastroparesis or a slow stomach. And we need to rule that subset out because that's treated entirely different. And that's done in radiology. It takes about 4 hours. Certain pictures are taken, and you come in and you come back a half hour later, take another picture. You eat a sandwich, and it actually tracks that sandwich as it goes down to the stomach. So 4 tests, and that completes in 90% of the cases, we'll complete the workup.
Very good. Thank you. Amy, tell me a little bit about what you experienced when you had to do that Bravo.
I definitely missed my PPI. There's a reason I was taking them. It just, I don't know. It definitely shows what he needs to see in order to determine that a TIF is necessary. There was a lot of acid production for sure. And yes, you can feel that thing inside your throat, but it's there for a reason. And I was happy on day 4 at 1:30 to take my PPI.
All right. Terrific. Well, just more I guess reinforcement that you were headed down the right path to go ahead and fix that. So that's great.
And Wendy, if I could interject here on the treatment that Amy just alluded to, the PPI, and typically it's omeprazole and Prilosec, it's very inexpensive and easily accessible. It's not a bad drug, it's a dangerous drug. And it's a why in the road that I have to talk to patients and talk them through that, because although you feel better, it relieves your symptoms, the long-term side effects of the PPI are essentially dangerous. And there was a study done, it was a 60,000 person VA study out of Canada. It was done back in 2010. And it showed that people on long-term PPIs have a 150% increased risk of osteoporotic bone-related fractures. And if you could just stay with me for a minute on the logic. You need acid in your stomach to absorb calcium. If you nullify the acid in the form of a proton pump inhibitor like omeprazole or Prilosec, you decrease the body's ability to absorb calcium and hence weaken bones over time, and hence 150% increased risk of osteoporotic bone-related fractures. And that's just the tip of the iceberg. There are studies that show decreased B12, decreased functioning of your gallbladder, increased risk of dementia, increased risk of renal insufficiency, renal disease, increased risk of nosocomial community-acquired pneumonia, increased risk of C. diff and some of the small intestinal bacterial infections. So there are many, many side effects of the PPI, and the patients, like Amy, have to, and we talked about it, you have to be educated on, yeah, we can continue that medication if it's working, but you have to understand those have long-term dangerous side effects.
Well, and also I'll add to that, a lot of what I see, I talk about my friend in Costco who was in front of me checking out and had, I think, literally 10 boxes of Prilosec because it was on sale. And so he was stocking up, and I just thought to myself and talked to him a little bit too, but just, what's drawing you to this versus something else? And he said, I asked if he'd seen someone, and he said, no, it's just working for me right now. Is it possible to be treating something it's not necessarily GERD? It could be something else.
Oh yeah. I mean, esophagitis, that bleeding ulcers, typically that'll warrant other symptoms, but the real hidden diagnosis is the Barrett's esophagitis, especially in white males over the age of 40. I can't emphasize that enough. That if you are taking these medications, you feel good, you could be masking that escalation of Barrett's esophagitis into adenocarcinoma of the esophagus, which is once it escalates into cancer, is a very, very poor prognosis, and it hasn't changed since 1972. It's a bad disease process. It's one that we want to work diligently at avoiding.
Good, thank you. So can you talk to us just a little bit about what options besides the medications are available to treat GERD?
There are several procedures available. The Nissen fundoplication is essentially where we wrap the stomach, the upper portion of the stomach, around the esophagus. It has been done for many years, since the early 90s. And Tom DeMeester, Jeff Peters were two surgeons in Southern California that really revolutionized the procedure. And it took hold. It was with us for many, many years and very effective at reducing GERD. However, it had two very bothersome side effects. And those were dysphagia, or difficulty swallowing, and also abdominal bloat. People would feel like they're pregnant every time they eat. And not just 2 or 3% of people, upwards of 40 to 60% of people. So it fell, I'm not going to say it fell out of favor, but it did because of those side effects. And there was really no way or no particular surgeon or technique that would reduce it. A toupee is a partial fundoplication in certain circumstances. Those are invasive procedures. They require laparoscopic incisions, several in the abdomen, and it takes upwards of an hour, hour and a half to do the procedure. So it's a lengthier procedure, and it necessitates incisions, which can be uncomfortable. More recently, the transoral incisionless fundoplication has come on board, the TIF procedure, which I was the second one in the state to do these back in February of '09. And I've found it to be extremely successful. It is non-invasive, meaning it's done through the mouth. There's no incision. I'm going to just quote some statistics here. 81% of patients long-term do not require any form of PPI. So we get off the medication that we talked about are dangerous. The meds are dangerous. 84% of the patients with esophagitis and inflammation of the esophagus will be healed. 78% of patients are satisfied with the result and feeling much better. And quality of life scores go along with it. So not only do you feel better, but we get you off of those dangerous drugs that you had been on for years. And the longevity is there too, 7 to 10 years durability. So, and understand that even the Nissen fundoplication does not last forever. That's 10 to 12 years in that realm as well. So I think the TIF procedure is effective at symptom resolution and getting one off their medications. At this point, it may be beneficial to see an animated video of the actual procedure to help understand what we're doing relative to that hiatal hernia and the reflux and that valve between the esophagus and stomach.
Very good. Okay, I think our producer is going to work on.
So what we saw in that animated video was the device being placed into the mouth, down into the stomach, and then basically plicating the esophagus to the stomach 280 degrees around to restructure that valve and make it look or structured like it was initially, like it used to be. There are polypropylene fasteners. A very common question I have is, do they last forever? And yes, they do not dissolve, but oftentimes they'll migrate. They are simply something to help the tissue what occurs with that tissue is serosal fusion. It's the scar tissue between that tissue 280 degrees around that will form within 14 days after the procedure. The fasteners simply they're like forms on a cement. You put the forms in, you lay the cement, take the forms away when the cement dries. Well, it's a similar concept. Those fasteners are simply devices to help that serosal fusion to occur over time. I can migrate into some of the post-operative care if you want.
Sure.
Wendy?
So before we jump into that, Amy, can you tell me a little bit about what drew you to TIF? Were there any characteristics about the procedure? How much did you research? What made you come in and say, okay, this is what I want to do?
Well, I work with Dr. Dargis, so I've got to hear about it a lot. And the more I heard patients say how happy they were after having it, I was like, huh, maybe this is something I should talk to him about.
Very good. All right. So we've had some questions come in. I feel like now is a good time to field those. First, we have Karen, who is asking, can I have the TIF procedure if I have Barrett's?
Yes, the answer is yes, but typically we treat the Barrett's, and I'll dovetail a little bit into the treatment of Barrett's for a minute. There's something, and I do these, so I'm very familiar with them. But there's something called the halo procedure, and it's where we go down and apply RF, radio frequency ablation, a light burn, if you will, to the area of the Barrett's. Now, typically that has to be done 3 times over the course of 8 weeks apart. So, but after that third treatment, so 8, 16, 24 weeks later, we do a third treatment, there's a 94% eradication rate. It does not preclude the fact that you need to be in surveillance, typically annual surveillance, just to make sure that the Barrett stays at bay. But we would want to eradicate the Barrett's first and then take care of the reflux. That's in my practice. Now, there are some variations to that. If you have real severe Barrett, kind of like we're trying to chase like chicken and the egg argument, where we keep treating but we're not getting better, then I'll talk to patients about correcting that hernia at that time frame, and then retreat the Barrett's after we correct the hernia.
Okay.
But the answer to the question is yes, you can have, and I would encourage something like a TIF procedure with Barrett's to help reduce any chance of additional acid up into that esophagus.
Excellent. Okay, thanks. So actually that is going to dovetail further into our next question from Jennifer, who asks if you can have a TIF if you have a hiatal hernia.
Yes, in fact, that's what the endogastric fundoplication or the TIF does. It corrects that hiatal hernia. Now, if we think back on initially, I mentioned the workup, inclusive of an upper scope, an EGD, and we had to measure the hiatal hernia. And we measure a hiatal hernia based on what's called a Hill grade, Hill 1, 2, 3, or 4. Typically, if it's a Hill grade 3 or 4, well, a Hill grade 1 or 2, we can correct it. In other words, the smaller hiatal hernias we can correct. The larger ones, we need to talk about something called a crural repair, which probably goes a little bit more beyond what we want to cover here today. But suffice it to say that regardless of the size of your hiatal hernia, it can be corrected, and ideally a smaller hiatal hernia with the TIF procedure.
Okay, very good. Next up, Chris is asking, how long should I take PPIs before I consider a TIF?
Well, short term, 2 to 4 weeks before you get a scope. I mean, that you hear that on the commercials, and I know that's a little remarkable to people that they think, well, I've been on it for years and I had a scope. Well, really, within 2 weeks, 3, 4 weeks of therapy, if the PPIs, even if they're working, you really should have a scope to rule out Barrett's.
Gotcha. Very good. Yeah, that's a good little soundbite there, Dr. Dargis, as a matter of fact, is even if your PPIs are working, have a scope to make sure that you're checking for that. April is Esophageal Cancer Awareness Month, and I think you just, you couldn't have said it any better than that. That's what we're really advocating for, is for people to get into a medical expert, to just get checked and make sure they know exactly what is going on. Even if they have medications that are treating their symptoms, the symptoms may not be what they think they're attributed to. So I appreciate you saying that. Okay, I have Christopher asking, my cousin had a Nissen, but has difficulty swallowing, which actually you touched on, and still has reflux. Does TIF have a place there? Is it a treatment option?
Yes, in fact, I lectured at the ASG years ago in front of a multi-center trial of post-Nissen TIFs, and very eloquent study. But the TIF procedure is an excellent modality for the loosened, we call it a loosened Nissen, where, remember, we talked, Nissens don't last forever, 10 to 12 years, and sometimes sooner, they will loosen. And the TIF procedure is an excellent way to go about retightening that valve versus redoing a Nissen. A redo Nissen is a very challenging, even in experienced hands, procedure. Um, and you need to be very careful. There's a lot of scar tissue to dissect through, a lot of potential complications. So the TIF procedure in that realm is an excellent way to go about it.
Good, thank you. All right, so we've covered anti-reflux treatment options. Let's talk now, and the TIF procedure in particular. Let's talk a little bit about what prepping for TIF looks like, and then the recovery side once the patient is the other side of the procedure.
Yeah, the preoperatively, just nothing to eat or drink the night before. We talked about the preoperative workup. We've got that all covered. But the procedure itself, I've done 500 of these. It takes about 42 minutes, and it's done under general anesthetic. Then you go to the recovery room. You wake up, spend about an hour there, and then you will spend a night in the hospital. And that more or less is to cover any side effects of the anesthetic. The last thing we want is to be throwing up. Um, One of the typical side effects after the procedure, and I counsel the patients extensively about this, is chest pain and difficulty swallowing. But that will only last about 48 hours. But you will wake up in recovery. You're going to feel that discomfort. We've done a lot of work there. Been treated for it for years. It's just inherent, but it won't last long. And then you go home the next day. You'll have about 6 weeks of a limited diet. And this is kind of customizable from surgeon to surgeon, but I will keep my patients on their PPI regimen for about a month after, and then I'll take the next month to wean them off. You don't want to stop the PPIs cold turkey because that can cause hypersecretion of acid and other problems. So I will typically keep them on for a month and then wean them to half of their dose, whatever they were taking. If they're taking 2 pills, they go down to 1. If they're taking 1 pill, they go out every other day. So I cut that back over the following month. But by month 2, we're eating a regular diet and we are off of medication. Amy, I don't know if you wanted to.
Yeah, tell me what you felt, Amy.
The first couple days afterwards are a little rough. I understand why the diet is made the way it is. You're not going to want to swallow anything more than water. It does hurt your throat, and you will feel the chest pain. I did. But Tylenol is your friend, and just follow the diet.
Oh, look at you. Very good.
Culture is your friend.
Excellent. Okay. What were some of your favorites, or just kind of your go-tos that either tasted good or didn't make you uncomfortable? What were the things that you gravitated toward?
Ice cream and sherbet.
Very good.
I didn't typically eat that a lot beforehand, but A, it helps numb your throat, and B, it tastes good. So, and it's on the list. So yes, that's what I did.
All right. And then as you progressed, lots of people have questions, about what were your what were your go-tos as you were able to advance your diet? Obviously, you didn't go from sherbet to, meat. What happened in between?
Um, Once I could have protein shakes, which were starting on day 4, I used those a lot. Once I could get into more textures, um, I got like ground chicken and ground turkey, and I would add like pesto or like some Italian seasoning stuff that's not very GERD aggravating. You learn to you learn to use your blender. Putting broccoli cheese soup in the blender was amazing. I'm not a big mashed potato fan, and this brochure is very like root vegetable mashed friendly. So if that's your stick, then you'll probably love that. But um, your blender, protein shakes, and ice cream.
Excellent. Great
Yeah,
tips.
the literature tells us that you'll enjoy about 75% more of what you enjoy eating. So if you couldn't eat pizza before, you're most likely going to be able to eat pizza. But there's going to be 25% of foods that you won't be able to tolerate. And at month 2, that's where I counsel my patients, hey, if we're going to reintroduce foods a week apart so you understand what is going to affect you and what isn't, whether it be spicy foods one week, Mexican food the next, alcohol the next, coffee the next. It's got to be sequential so that you better understand what you're going to be able to tolerate and what you're not.
Well, and I love the duration that you suggest with that. The week to week is really, really smart because then it does give you a good idea of what's affecting you. Something that we have available to folks that is completely free of charge. If you're thinking about this post-operatively, it might be a great tool to use. We have a mobile app. It's called GERD Help. If you go to your app store and you type in GERD Help on your phone, you can load that app and you can actually keep a journal of what your intake is, also your symptoms when you're having them, and you can keep track yourself of what might be, taking you a little bit too far, or the things that you're responding to really, really well. So just a food for thought there. May want to go ahead and look into that. Okay, so Amy, can you talk a little bit about when you started resuming some of your normal activities, and then Dr. Dargis will go ahead and have you circle back on that and see if she did the right thing.
Like I said before, I followed the brochure pretty closely. I tried to, it says to walk around as much as you can in the first couple weeks. And of course, I tried to do that. Once I got back to work, it was a lot easier. But I didn't have a lot that I did that was restrictive anyways. So I can't really speak to, like, I'm not a gym goer or anything. So I don't know what weightlifting and stuff like that really would do. But yeah, just follow the brochure.
Very good. Okay, and tell me a little bit
Right.
about your work. When were you able to return?
I did take the week off. It was the week of Thanksgiving, so it was pretty easy for me to do that. I'm not sad that I did because the first couple days I just was like, "Oh man, what did I do?" But yeah, I say a good week is good to realize what is going on with yourself and get used to a restrictive diet. Like it can be kind of intimidating, but if you understand that your food tube is been massively manipulated, it makes sense to gradually go into the things again.
Yeah, typically I'll suggest no lifting over. I encourage return to activity, up and down stairs, getting around the house, doing what you want to do to prevent blood clots. And that's inherent with any procedure. But no lifting over 10 pounds for about the first 2 weeks, no lifting over 20 pounds for about a week after that. But by week 3 and 4, you're back to lifting, doing what you want to do.
Very good. Thank you. Okay, so can you talk a little bit about just any? I'm trying to think of Michigan, sports in the summertime, Dr. Dargis. When are folks going to want to get back to water skiing or running, being outdoors, golfing?
Yeah, I'd say as long as you're not lifting anything over 10 pounds, you're not lifting your bag, you're riding around the course, or you're not lifting anything over your head, I'd say you get back with it within 2 to 3 weeks.
Correct. Okay, thanks. All right. So can you talk just a little bit about, your life after your recovery? Just what are tips for success for patients to continue, living the dream once they're recovered and they've put in that investment of those weeks of that modified diet. What are the things that they do to keep things going in the right direction?
I think avoiding those foods that you know are going to incite your symptoms, carbonated beverages, alcohol, smoking, those are long-term lifestyles that are going to affect, the repair long term. Um, Everything in limitation. I think you can enjoy more of what you like to do and what to eat, like to eat, but I think limiting that will help the duration. Maintaining a BMI under 32 is real important too. As we increase our weight, that inherently puts more pressure on that repair and could cause issues long term.
Interesting. Okay, very good. Thank you for that. Amy, Haley actually just asked this question. After listening, I'm thinking I may be a TIF candidate. What would you say to the person who's been putting it off? Was it worth it for you?
Yeah, I think so. I've learned a lot. Like, I may not be able to eat certain foods anymore, but I know, like, it's a lifestyle change too. I try not to eat after 7. I try not to lay down after I eat. I try to move around more after eating.
Great. With all that activity, did you notice a difference in your appearance? Are you feeling better?
I feel a lot better. I actually lost about 20 pounds from having the procedure and the limited diet and sticking to some things. I do, when I bend over now, I don't feel like stuff's going to come out of my throat. Yeah, it was worth it. It's a scary step to take to some probably, but you don't know till you ask.
Very good. Thank you. So Dr. Dargis, we're getting to the end of the program. Can you tell me, just do you have any parting thoughts for our viewers tonight before we sign off?
Yes, esophageal cancer is a parabolic curve increased risk in the general population since 1972. It's growing. It's growing quickly. It's growing quicker than any other cancer. And so that's point one. Point two, PPIs, Prilosec, omeprazole, dangerous drugs long term. Dangerous drugs long term. Yeah, you really need to work on getting off of those medications. And there's plenty of options, the TIF being one of them, that will work.
Good. Thank you. Well, I want to tell you both how much we appreciate your time. Our audience has gotten a lot out of it. I want to thank everybody for their questions. For tuning in to our episode this week. If you would like to find out more about the TIF procedure or to find a TIF physician in your area, if you're not in Hastings or in Southern Michigan, you can certainly go to gerdhelp.com and enter your zip code in our physician locator tool. That will show you TIF specialists in your area. And if you're in the Hastings area and you punch in your zip code, you'll see Dr. Dargis right there. There is also that free mobile app that I mentioned that you can use to keep track of your symptoms, which will help your doctor with diagnosis and treatment of your GERD. You can go to the App Store, search GERD Help, again, all one word, to download that app. It is free of charge to use. It's been a pleasure learning from you both tonight. I know the audience feels the same. I look forward to continuing to watch how you promote this education within the community, and I'm so appreciative of your partnership. Everybody, good night. Thanks for tuning in. We'll see you for another TIF Talk soon. Take care.
Thank you.
10+ weeks out from surgery, it's pretty surreal that I keep waiting for heartburn to happen. I keep waiting for the GERD symptoms to come back after I start, implementing foods that I can eat again. And it's not happening. I feel very happy. I feel very grateful. I feel solid in knowing that the TIF procedure worked. I've been running again. I can do push-ups. I can bend over and pick something up without acid coming up into my throat. Yeah, I'm serious. I mean, that's where it had gotten. The dry mouth and the dry throat and dry esophagus, it made it really difficult to speak. And I would get a sore throat a lot from sleep. When I would sleep, the acid would come up into my throat and I would wake up with a sore throat and a hoarse voice. Now I wake up, maybe I think about it because I'm conditioned to think that way, but the cool thing now is that if I do have that thought, which is fluttering away each day, but if I do have that thought, I quickly can scan myself and there's no heartburn, and there's no sore throat, and there's no wheezing, and there's no fear about having a cup of coffee. I just don't wake up feeling defeated and sad and down. I mean, if somebody is having severe GERD symptoms and they've exhausted all their options, even if they haven't exhausted all their options, if they have severe enough symptoms like the symptoms that I had, I would 100% suggest the TIF procedure, because it's been a complete 180 to the way I feel and for the things that I'm able to do now. So if somebody has severe GERD symptoms, chronic acid reflux, I would 100% recommend the TIF procedure.